Introduction. When you hear hopeful news about neuroprotection for glaucoma, it's natural to wonder what that means. In glaucoma, the goal of neuroprotection is to protect the eye's nerve cells, the ones that carry signals from the eye to the brain, from damage. In other words, neuroprotective treatments aim to keep the optic nerve healthy and alive, not just by lowering eye pressure, the pressure inside the eye, called intraocular pressure, but by directly shielding nerve cells from injury. As one Cochrane review explains, neuroprotection in glaucoma is any treatment intended to prevent optic nerve damage or cell death. However, a recent analysis, March 11, 2026, highlights why proving neuroprotection in people is so challenging. The study points out that glaucoma often progresses very slowly and that the usual tests used to measure optic nerve health can be noisy, so it's hard to see clear benefits over a short time. In this article, we will explain what neuroprotection means in glaucoma, how it differs from the familiar approach of lowering intraocular pressure, and why this new paper, and others, say neuroprotection trials face big hurdles. We'll also discuss why many treatments that look promising in the lab fail to become real-world therapies, what kind of evidence doctors need to be convinced a treatment truly protects nerves, and what all this means for patients hoping for more than pressure-lowering therapies. Neuroprotection in glaucoma. What does it mean? Glaucoma is essentially a disease of the optic nerve, where the retinal ganglion cells, the nerve cells in the eye, gradually die off. This death of nerve cells is what causes vision loss in glaucoma. Right now, all approved glaucoma therapies focus on lowering intraocular pressure, which is the main risk factor for nerve damage. By lowering eye pressure with drops, lasers, or surgery, we can delay glaucoma from getting worse. However, even when eye pressure is well controlled, some nerve damage can still happen. That's why scientists talk about neuroprotection, treatments that go beyond pressure lowering and try to directly save or strengthen the nerve cells. For example, imagine a treatment that boosts the survival of optic nerve fibers or blocks harmful chemical processes in the nerve. If such a treatment were proven to slow down nerve damage, we would call it a neuroprotective therapy. In contrast, a pressure-lowering eye drop does not directly heal or protect the nerve. It simply eases the pressure on it. And restoring lost vision is an even bigger leap. That would mean regenerating or replacing the nerve cells and reconnecting them to the brain. Currently, that level of nerve regeneration is largely experimental. Ideas like gene therapy or stem cells are being studied, and is not an available treatment. To sum up, lowering eye pressure reduces the mechanical stress that contributes to glaucoma. Slowing nerve damage is the job of neuroprotective interventions, if we had them, and restoring lost vision would require repairing or regrowing the damaged nerve, which is still far in the future. Lowering pressure versus protecting nerves versus restoring vision. These three goals, pressure lowering, neuroprotection, and vision restoration, are related but different. Right now, pressure-lowering treatments are the only proven way to delay glaucoma damage. By contrast, neuroprotection means adding something on top of pressure control that would guard the nerve cells by other means, for example, with drugs that block cell death or improve blood flow to the nerve. Finally, vision restoration would involve regaining what was already lost, such as by regenerating nerve cells. In glaucoma, once nerve cells die, vision loss is generally irreversible, so restoration is a much tougher goal that remains experimental. Doctors emphasize that even with good pressure control, some patients still slowly lose vision. As one expert review notes, retinal ganglion cell death is the main cause of vision loss in glaucoma, and lowering pressure may be insufficient to prevent glaucoma progression or RGC loss in some patients. This is why there is hope in the research world for neuroprotective treatments. But as we will see, proving that a treatment actually protects nerves in people has turned out to be very tricky. Why neuroprotective treatment trials are so hard. The recent paper explains that several practical hurdles make it very difficult to prove a treatment is neuroprotective in primary open-angle glaucoma. Here are the main challenges in simple terms. Glaucoma changes slowly. In many glaucoma patients, vision loss happens so gradually that it can take years for noticeable changes to appear. Even over 5 years, a patient with treated glaucoma might lose only a small fraction of vision. This means any trial trying to show a benefit of a neuroprotective drug must be very long or involve many patients. Indeed, past large trials of neuroprotective drugs have enrolled thousands of patients over several years. For example, a trial of the drug memantine, initially tested for Alzheimer's, included nearly 2,300 patients followed for 4 years and still found no slowing of vision loss. In fact, one analysis estimated that a new trial might need over 2,000 participants tracked for 4 years just to detect a moderate effect. Nerve damage is hard to measure quickly. The tests doctors use to track glaucoma, standard visual field exams, and optic nerve scans, like OCT imaging of the nerve fiber layer, have natural variability and only change slowly over time. Day-to-day test results can jump around a bit, and small improvements might be masked by noise. The research article notes that outcome measures like visual field loss are noisy and may miss subtle neuroprotection. Today's trials try to use more sensitive measures, for example, tracking rates of nerve fiber thinning on OCT or electrical tests of nerve cell function. But even so, picking up a slim benefit in a short trial is tough. Trials need to be large and long. Because of the above, trials must be big to have enough statistical power to see any difference. Earlier glaucoma trials show this clearly. To see a modest slowing of vision loss, you often need hundreds or thousands of patients. And because it's unethical to withhold standard care, everyone in a trial will receive the best pressure-lowering treatment already. So a new neuroprotective therapy is tested on top of that, meaning the extra benefit over standard therapy tends to be small and requires even more patients to detect. One review pointed out that without using a placebo, doctors can't just give no treatment to half the patients. Sample size requirements would be substantially larger than older trials that compared treatment to nothing. Study design is complicated. Tied to the above, designing a fair trial is tricky. Since it would be unethical to deny anyone pressure control, new treatments are tested as add-ons to regular glaucoma care. In other words, all participants get a standard IOP lowering regimen, and half get the extra neuroprotective agent, while half get a dummy, placebo. This makes the extra effect harder to see. The March 2026 paper notes that many past neuroprotection trials had an inevitable bias. By the time they ended, nearly everyone's nerve damage had progressed slowly, so separating groups was difficult. In addition, long trials sometimes suffer from dropouts. Patients may switch treatments or leave the study, which further muddies the results. In summary, because glaucoma is slow and subtle, because tests have variability, and because trial designs are challenging, even a helpful treatment might not show a statistically significant benefit in the usual 2 to 5 year clinical trial. Researchers say it's like trying to see a faint ripple in a vast ocean. It's easy to miss. Why promising lab results do not always become real treatments. It's easy to understand the lab and animal research where neuroprotective effects often seem very promising. In a petri dish or a mouse model, scientists can give cells a damaging insult and then add a test drug immediately at high doses, and they sometimes see clear protection of nerve cells. But human eyes and diseases are much more complex. Many things can go wrong when moving from lab to clinic. Dose and delivery. What works in a small animal might not reach effective levels in a larger human eye, or might not stay long enough. Some treatments require injections into the eye, which carry risks, or very high doses, which might not be safe or practical in patients. Side effects. A neuroprotective compound might be safe for lab animals, but cause side effects in people. For example, high doses of vitamin B3, nicotinamide, showed nerve protection in mice, but in humans it can cause nausea or liver issues, so dosing must be cautious. Complex biology. Humans have more variability. Age, health, genetics, and other factors like blood pressure, diet, or other diseases can influence results. Animal models can't capture all these differences. In fact, many treatments that looked great in animals have failed in human trials. The paper reminds us of a few examples. Memantine, mentioned above, was a big hope because it blocks harmful brain chemicals in animals, but 2 massive clinical trials in glaucoma patients showed no effect on preserving vision. Another example is brimonidine, an eye drop already used to lower IOP. Some data suggested it might protect nerves, but a large trial comparing high-dose brimonidine to another pressure drop, timolol, did not provide convincing proof of benefit in practice. Even experimental therapies like gene or cell treatments that regenerate nerve cells have encountered setbacks. In one reported study, injecting a patient's own cells into the eye showed no improvement in vision and even worsened one patient's eye pressure. The key message: success in the lab does not guarantee success in people. Every step of translation, from animal models to small human trials to large studies, can reveal unexpected issues. That's why doctors and researchers remain carefully skeptical until multiple human trials show a clear benefit. What kind of proof doctors need to call something neuroprotective? With these challenges in mind, what evidence would convince eye doctors that a treatment is truly neuroprotective? In plain language, doctors need well-designed human trials showing that patients given the treatment have slower vision loss or nerve damage than those who receive standard therapy alone. This usually means visual field tests. Patients take regular visual field exams. If the drug works, the treated group should lose fewer points on their fields over time compared to the control group. The difference must be statistically significant and clinically meaningful. Optic nerve imaging. Doctors may use optical coherence tomography, OCT, to measure the thickness of the retinal nerve fiber layer. A neuroprotective drug should show less thinning of this layer over time. Many new trials now use these imaging biomarkers in addition to fields. Other functional measurements. New cardiac tests, like pattern electroretinograms or specific electrical tests of ganglion cell function, might be used to catch subtle protection early. Even things like color vision or contrast sensitivity could be tracked. Long-term follow-up. Ideally, patients are followed for several years to confirm sustained benefit. 1 year or two might not be enough to prove a long-term effect, given how slow glaucoma is. In short, doctors look for strong statistical evidence from randomized clinical trials that a treatment slows the progression of glaucoma beyond what standard IOP-lowering care achieves. A single small or short study is usually not enough. That's why the field has not yet declared any new drug neuroprotective, even though many candidates have biological reasons to help. Large confirmatory trials are still needed. Why promising lab results do not always become real treatments. Repeated section heading to highlight this important point. As discussed above, laboratory and animal studies often suggest awesome possibilities, but human trials have been disappointing so far. Memantine and brimonidine are two high-profile examples that worked in animal studies but failed to prove a vision benefit in human glaucoma patients. Similarly, supplements like vitamin B3, nicotinamide, or citicoline showed very encouraging protection of nerve cells in preclinical tests, but only small improvements in preliminary human reports. Patients and news stories sometimes latch onto these promising early results, but doctors remain cautious. Until there is clear evidence from large human studies, treatments remain unproven. What this means for patients hoping for more than pressure-lowering treatment. For now, this means that lowering eye pressure remains the cornerstone of glaucoma care. Patients should continue using their prescribed eye drops or other pressure treatments diligently, because this is currently the only proven way to slow damage. If you hear about a new miracle cure coming soon, keep in mind that experts warn it is very hard to prove such cures work in people. The research is active, and there is hope that in the next several years, new therapies, perhaps involving vitamins, injections, or even gene therapy, will prove themselves. In fact, some scientists remain optimistic that with smarter trial designs and better imaging tools, we might see officially approved non-pressure medications within the next decade. Until then, it is wise to be realistic. Ask your doctor before trying any new supplement or off-label treatment. Some patients and doctors do discuss things like high-dose vitamin B3 or citicoline in hopes of extra protection, but these should only be used under medical supervision. High doses of supplements can have side effects. Most importantly, stick with studies that are already shown to help. Use your eye drops as recommended, have regular checkups, and immediately report any vision changes. This diligent care is your best defense against vision loss right now. What this means: currently, no neuroprotective drug has been proven for glaucoma, so stay on proven IOP lowering therapy. Keep an eye on trustworthy news about research. This field moves slowly. The good news is that researchers understand the challenges better than ever. With new technology and smarter trials, a true neuroprotective treatment may eventually join our toolkit, but it will need solid evidence first. In the meantime, patients should stay informed, hopeful but realistic, and work with doctors to manage glaucoma with the best tools we already have: pressure-lowering treatments and regular monitoring. What this means for patients hoping for more than pressure-lowering treatment. For now, focus on controlling intraocular pressure and protecting any vision you have. It's perfectly fine to be interested in future therapies, but remember that real proof takes time. By staying informed and following your doctor's advice, you'll be best prepared to benefit from new treatments once they truly arrive. Tags: glaucoma, optic nerve, neuroprotection, intraocular pressure, vision loss, clinical trials, eye drops, retinal ganglion cells, glaucoma treatment, ophthalmology. All links to sources are available in the text version of this article. You can find the full article at visualfieldtest.com. Thanks for listening. To check your visual field, click the link at the bottom of this article or visit visualfieldtest.com.